Good afternoon, Dr. Inkster. Mr. McIntosh.
Thank you, my Lord. Dr. Teresa, what I want to turn now to is the cases involving Mycobacterium chelonae.
Yes.
Now, you covered that in quite a lot of detail from paragraph 807 onwards in your statement, page 260. I'm not going to go there because I want to just ask you some general questions about the cases and how they fit into events. So just to get our context, we have a case in, well, the blood test result is the 16th of May, 2018.
Yes.
And that's a patient who at that point is in Ward 2A.
That's correct.
And then we have another patient in is it June 2019?
Yes.
Who is in 6A.
Yes.
And one of the issues that's arisen, I don't know whether you're aware of this, is that with his agreement, I'll use his name, Professor Cudahy, who's the parent of one of the children,
Yes.
has been concerned that his daughter's case in 2018 doesn't emerge within the Oversight Board's timeline or an initial document produced by the Case Notes Review, or indeed the first report produced by Dr. Mumford and Miss Dempster for this inquiry in a chronology in all three cases. Were you aware of this?
No.
We've done some investigation, and I wondered if you might be able to comment on whether this seems possible to you. Could it possibly be that a result that discloses a positive Mycobacterium chelonae result might be described in the spreadsheet of BSI results that we have as gram-positive bacilli instead? Is that a possible alternative way of describing it?
That is possible because in the laboratory, when you have a atypical mycobacteria or non-tuberculous mycobacteria like chelonae, that's how it would first of all be classified in a patient's blood culture. And to identify these and to confirm the identity of these, we would send them to a reference laboratory. And we have had significant challenges that date back to my days in Glasgow Royal Infirmary with how we handle reference laboratory reports and how they come back to the department, because the system is not electronic. So it is paper-based.
So a paper comes back?
Yes, and then it's reliant on the system being updated and the result being typed in. So it may be that the actual part of the system the extract has come from has only captured the gram-positive bacilli. So,
and that would have been the original entry?
So that is entirely possible that that could have happened.
That's very helpful. And if we look in your statement on page 320, paragraph 1040, this is about the case note review. Do you think this might have been the cause of this, or part of the cause of this particular problem?
So the data I'm referring to here is whole genome sequencing reports.
Oh, well, then it isn't. So we'll move on. That's fine.
Mm-hmm.
Now, the other thing is that we gave you in the document list Dr. Mumford and Miss Dempster's report. Did you see that?
Yes, I did.
And we took you to a footnote.
Yes.
Did you see the footnote?
I saw the footnote.
Right. Are you aware of a Mycobacterium chelonae case in the Schehallien unit in early 2016?
Only from the case note review report.
Right. And from the Dr. Mumford finding it in the database. That seems to be a bit of an oversight. Or I suppose, were you around in early 2016 when it would have come out?
No, so at the time of the positive result, I was the regional ICD covering just parts of the adult hospital. At that time, we hadn't integrated with paediatrics, so I wasn't providing any paediatric microbiology cover. So I had no infection control or microbiology remit for the RHC at the time.
So if there was such a result, how would the system in early 16 have reacted to a microbiologist seeing it in the results for a patient?
So it would be dependent on that microbiologist defining that as an unusual bacteria or something of interest. and then they would then have to forward that information to the infection prevention and control team.
And if the infection prevention control team received that information, would they then have to decide whether to commence the high alt process at that point?
Yes, so anytime an infection control member gets an email like that, it doesn't necessarily result in a PAG, but it does result in a review. So the ICNs would review the case, collect information about the case, it would be documented on ICNet, and then they're certainly in that sort of case where it's an unusual bacteria, speak to an infection control doctor about what to do next.
So if they had been reacting in the way you described, it would be on the ICNet system.
If they were told about it, I would imagine they would, so there wouldn't have been a transfer across to ICNet.
Right.
But if they were told about something and they went to review it, they would be recording that.
Yeah, so in a sense, if we don't find records, are we entitled to infer that it never left, in a sense, the microbiologist, never got to the infection prevention control team? Or is that a wrong inference to make?
I think it would be highly unlikely for the ICN team not to respond and document something that was referred to them. I can't imagine a situation where they wouldn't.
Does this expose any issues about the systems? Because when it comes to 2019 and you are reviewing the Microbacterium tonei case in 2019,
yes,
we've seen from the IMT minutes, I won't take them to you, that you then discussed the previous case
yes,
in 2018. And one imagines it would have been interesting to know about 2016 case as well.
absolutely, yes.
Would it have changed your behaviour to know about it anyway?
It would have strengthened the hypothesis.
What was the hypothesis?
That the infections were caused by the water system. If I'd had the knowledge of the 2016 case and obviously all the knowledge I had about the DMA report, so I would have reached that conclusion on the basis of the increase in numbers before I got whole genome sequencing results.
And what would be your reason for a third infection increasing the strength of the connection in your mind?
I suppose it's an increase in numbers over a defined time period above what we would expect to see. These are incredibly rare organisms, but to see 3 in essentially 3 years.
And are these one of the cases where there's no background, if we refer to our conversation before
Yeah,
that?
we would not expect to see background of M. chelonae. That doesn't apply to all non-tuberculous mycobacteria because there are some patient populations where you might see colonisation, like cystic fibrosis and also HIV patients, but not within a hemato-oncology population. You would not expect a background rate.
Now, I want to pick up something that relates to the interface between Microbacterium chelonae and the chlorine dioxide system. If we could start up again to an IMT minute, which is bundle 1, document 72, page 320. So we see this is the IMT from the 19th of June. And so if we were to go down to page 321, we have a bit of discussion from you, I imagine, about the case and the previous case. But it's over the page that I want to look onto 322. And at the top, you have reported recent water sampling from 6A has found a marked reduction in gram-negative bacteria. Was this a trend that you could describe, or was it just a step or an unusual change here?
The recent water sampling, do you mean?
Of the gram-negative bacterium, just as it's passing over. Could you say there was a trend of reduction, or was it just behaving oddly?
No, there was a reduction, which we would expect, I think, at that point in time.
Why would that be?
Because we'd started dosing with chlorine dioxide.
But we move on to the second sentence. Microbacterium is isolated for a number of points. These are random outlets chosen for sampling. What sort of outlets were they?
Those were taps and showers on ward 6A.
These samples were taken with the point of use filters off. So would I assume that's they're in the water system?
Yes.
Right. And TI explained that chlorine dioxide has been very effective against gram-negatives, but atypical mycobacterium persisting. They are likely more resistant to disinfection. Can you sort of provide an evidential basis for this?
So at the time, we had the water technical group running. It's obviously a very complex incident, lots of experts involved, including Paul Filters themselves, the company, and they had a microbiologist who worked for them called Vicky Katsemi, who travelled over from Germany and has a lot of experience in water systems, and came to my office and we had a chat about various things. I was telling her the challenges that we were having at the time with the gram-negatives and the atypical mycobacteria. And she said to me, you need to read the work of an individual called Joseph Falkenham from the University of West Virginia in the States, who's a leading authority on non-tuberculous mycobacteria and water systems. And Vicky herself had a fair amount of knowledge about non-tuberculous mycobacteria, but she directed me to his work. He has published many, many papers on the subject. And indeed, within these papers, he discusses the challenges of eradication of these from hospital water systems because they are resistant to disinfectants, including things like chlorine dioxide. So once they're in a hospital water system, very, very difficult to eradicate. I don't know if you're aware of the most recent publication by NHS England on non-tuberculosis mycobacteria led by Suzanne Lee.
You were part of the author team for
I
this?
was part of the author team for that, but basically the consensus is in relation to NTMs in a hospital water system, your focus has to be on...
So NTMs?
Sorry, M. chelonae is a non-tuberculous mycobacteria, sorry.
Sorry, that was all rather quick.
Yes, I think you need to slow down this point.
So non-tuberculous mycobacteria are a broad group of bacteria of which M. chelonae is one. And this group of bacteria are found in hospital water systems. And the consensus for how you would approach these is not disinfection, but protection of the patient population. So identification of high-risk patients, application of point-of-use filters, which are effective against NTM, and also addressing the routes of transmission. And there's a lot of guidance around how you would design and maintain a new water system for a new unit with NTMs in mind and protection of vulnerable patients.
And do we see, in a sense, part of this discovery by you reflected in an email of the 27th of September 2019, Bundle 14, Volume 2, page 585? Email from you to Alison Hurst and Ian Kennedy.
That's correct, yes.
So what I want to do is take that. So what do you think was causing? Well, I think you've already answered that, so I won't come back to that. What I want to do is take that off the screen and look at your interactions with Professor Cudahy around the duty of candour to him. Now, you've described this in some considerable detail in two places in your statement. You cover the meetings in round about paragraph 1164 onwards, and you cover other sections about paragraph 827. So before we look at any of these, I want to just get some chronologies in date. Am I right in saying, reading your statement, that you have an original intention of sequentially meeting the parents of the second 2019 case and then Professor Cudahy with Jamie Redfern to brief them in or about the 26th of June 2019?
That's correct, yes.
Right. And then I'll come why it doesn't happen in a moment, but that doesn't happen for Professor Cudahy. So you have a second, well, it's not the second meeting, but the meeting happens at a later date on the 8th of August, after
Correct.
Jamie Redfern's been on holiday.
Yes.
So I have the chronology correct. Now, what I want to do is, I think, is go to paragraph 827, page 265. So this is a section where you're describing the meeting with the first family at 826. You've got that there?
Yes.
And then 827, Professor Gibson and I were insistent that the minute the first family left, I would go and speak to the second family with Mr. Redfern. I got to Jamie's office. I was made aware of a phone conversation that Jamie had with Kevin Hill, in which he was told we were not to contact this parent. Now, I was made aware covers a range of different things. How did you actually learn about this conversation? Were you there? Did you hear it? Did someone tell you about it?
Jamie Redfern told me when I walked into his office. So I left the meeting with Professor Gibson and the other family, went to his office, and he told me that he'd just been off the phone from Kevin Hill.
And as a consequence of that, the meeting didn't take place with Professor Cudahy.
That's correct.
Right. Now, if we then step forward to the actual meeting, which you cover from paragraph 1168 on page 359. Previous page, please, so 358. The bottom, I then had the meeting with Jamie Redfern, we know it's Professor Cudahy, on the 8th of August. Over the page. And then you just learn, you think at the time that he's heard about it from the other family. And is there some suggestion that the chairman's written a letter in the intervening time?
Yes, so at the subsequent IMT, following on the one from myself and Brenda Gibson talking about speaking to the parents, there was a report from Kevin Hill that the chairman, I'm not sure if he said had written a letter, but the chairman had communicated with Professor Cudahy.
Right. So as far as you're concerned at this point, you think the chairman's communicated?
Yes.
Right. Now, you then say you have a discussion with Jamie Redfern and you describe what you described there. Now, we've heard the evidence of Jamie Redfern and we've heard the evidence of Professor Cudahy. And we can compare the three, and no doubt I'll make submissions and others will too in due course. But I want just to go to the bottom of the page. And you describe in the last line that Jamie was getting more anxious and Professor Cudahy was getting more angry. And I recognise that what Jamie was saying wasn't over the page true. In what sense was it not true?
So we had agreed at the IMT that we would undertake communication with Professor Cudahy. We were advised not to.
And that's the conversation when you walked into the room?
Yes.
Right.
But Mr. Redfern's reasons to Prof. Cudahy as to why we hadn't contacted him were that, first of all, he had been on holiday, and then he changed his reasons, and then he said that it was agreed at the IMT, which it was not.
And that's why you said what?
I said, tell Professor Cudahy the truth, Jamie.
And what are you referring to in that, A, what's not true, and who isn't telling the truth at that precise moment?
So the reasons for communicating with Professor Cudahy at the same time as the other family were not true. Because it wasn't because Jamie Redfern was on holiday. We had intended to communicate with him at the same time as the other family, and it was not an agreed IMT process. There was no agreed IMT process not to communicate to a parent.
And what was the reason that you had not communicated with the Cudahy's before?
We were told not to.
Were you told at any point not to tell the truth?
No.
We've got your version of events. Have you ever given a different version of events to anyone else?
No.
Can I take you to Dr. Deegan's report, produced for Dr. Armstrong in May 2021? That's Bundle 27, Volume 6, Document 6, page 91. I don't know whether you had the opportunity of listening to Dr. Deegan's evidence when it took place.
Yes, I did.
Right. If we go to the appendix, which is at page 102, this is we're told, is a summary by Dr. Deegan of an interview that took place between you and Dr. Green and Mr. Gardner on the 6th of January 2020. Did such an interview take place?
It did, yes.
And were you told in the invitation that it was at the request of Dr. Deegan?
Yes.
Did you know what it was for?
The reason for the meeting was because I had raised concerns in my resignation letter to Dr. Armstrong about these three issues: the SCI process, duty of candour incident, and the governance of IMT. So it was a follow-up to that.
We see at the bottom of the page there's a section duty of candour incident, and then you see that 4 lines down it goes in the middle of the line that starts "have come from water." TI was to perform duty of candour with both families to alert this finding. However, when telling the first parents, she and the GM, I'm assuming that's Mr. Redfern, for the area were stopped as they were told a letter was going from the chairman to this parent as a number of other issues had been raised. Do you think you would have told that to Dr. Green?
I don't remember a letter being mentioned. It was communication, but I may have. I don't recall.
And then it says, TI then met with about the other issues, and it, over the page, became apparent that he had not been told about this. I'm assuming that's Professor Cudahy.
Yes.
And so felt that telling the truth about the investigation and findings was the only course to be taken. It then says she was told by the lead nurse of infection control that she was not to tell the family this detail. Did you ever say that to Rachel Green?
No, there was never any direction from a lead nurse for infection control. No infection control nurses were involved in that duty of candour incident.
Was there any point when any infection control nurses or associate directors told you anything about this?
No, never.
Can you think of a reason why Rachel Green's transcribed note summarised by Dr. Deegan might have that in it?
I have no idea.
Have you ever seen this document before, apart from its arrival in the inquiry?
No.
Were you given a minute of the meeting with Rachel Green?
No.
Were you given a copy of Dr. Deegan's report?
No.
Just for context, this is May 21, this report.
Yes.
When did you leave the employment of NHS Greater Glasgow?
September 2023.
Okay, thank you. We'll take this off the screen. I'd like to go to page 362 of your statement. Statement bundle, page 362, please. So you're referring, I see, at paragraph 1187 to a positioning paper produced on behalf of the Health Board. Do you remember reading that document?
Yes, I do.
And you've copied an extract from section 40 of that document.
Yes.
Did you ever tell anyone that you had been instructed to lie to the parents of a patient?
No.
Can you think of a reason why this allegation might be made against you?
I don't know.
Could it be that they're relying on the report of Dr. Deegan?
That's possible, yes.
Is there any other person you've ever told that you had been instructed to lie to Professor Cudahy?
No.
If we go to page 1280 of the that doesn't sound right. Paragraph 1280. Page 348 of your statement. This is another extract from that positioning paper. It's section 63 at paragraph 1121, and it relates to a different incident. I wonder if you can help me, without using the names of the family, put this into context. What was going on the 17th September 2018 in terms of infections?
So that was towards the end of the water incident, but that was the time where we were having issues with the drains.
If we can look at the IMT for the 10th of September, which is referred to in that extract from the positioning paper, which is bundle 1, document 36, page 154, which is an IMT that you're chairing on the 10th of September. Do you see in the after the large redaction, there is a, I'm just going to get this on my right page. If we look in the big paragraph below the big redaction that begins BG, and we look 3 lines in the bottom of that paragraph, there's a sentence that begins, TI noted that the patients with E. coli and Serratia isolated from blood cultures were not included, as neither of those organisms had been found in the drains or water. Was that true on the 10th of September?
It was true on the 10th of September, yes.
Can we look at the IMT? And we're not going to put this on the screen. My Lord, I provided, I'm reducing the level of redactions on the next page. So I provided the core participants and Dr. Inkster and you, my Lord, with a single page sheet, which is there, yes. And this is page 160 of bundle 1. If you've got that, Dr. Inkster.
No.
I think it will be passed to you by my colleague. Donation. Oh. So this is bundle 1, page 160, and it's an IMT minute of the 13th September. Now, what I've done, we can put the actual normal hearing bundle on the screen at this point. Page 160. So this is an IMT minute that you chair on the 13th September, and do you see that there is, in the patient update, quite a large redaction of 3 lines?
Yes.
And the second sentence of the large redaction refers to a patient who had a Serratia blood culture on the 5th of September. Is there a connection between the patient who had the Serratia blood culture on the 5th of September and the family who are referred to in the paragraph we were looking at in your statement in response to the Health Board's positioning paper?
I can't absolutely confirm, but it would be highly likely with the timeline that would fit with myself and Dr. Rongi then speaking to the relevant family.
Because if we go back to the page on the statement that we were looking at before, statement bundle, we can go and read the evidence, the statement of this family, and in their statement they say that their child had a positive test for Serratia on the 5th of September. Now, if we look at the paper copy that those of us in the room have got, do we see the patient was in ward 2A?
Yes.
Yes. And we go back to the hearing bundle on the screen, page 160. What are you recorded as informing the IMT after the redaction? Starting with Serratia.
Oh, so it hadn't been in the case definition to date because it hadn't been identified in the drains. But after the patient had been admitted, we found it in the drain, and then we included that as a case.
So why would you have told the parents of the child on the 17th of September that there might be a connection between their child's infection and the drains?
Because at that time, I was supporting the clinicians in the ward with duty of candour because it was a very complicated incident and very difficult for them to explain the infection control and microbiology aspects. And generally speaking, what I would do was talk parents through how we would approach the investigation and what stage we were at and what potential source would be. I would always explain to them the difficulties of, definitively connecting the drain to the patient case and the need to send isolates for typing and get further information, but I would be open and transparent with patients about the investigations that we were undertaking and what we were thinking at the time.
And so do you have any particular response to make to the suggestion that you the information you gave to the family had no factual basis on the 17th of September?
No, because I was being open and transparent with the family about an investigation as per duty of candour and as per GMC guidance for a doctor.
How do you respond to the suggestion that you some way misled the family?
I don't believe I misled families. Like I said, it can be very difficult to communicate complex outbreak and uncertainty, and I would do that to the best of my ability with a clinician present. Between us, we would explain that we were looking for sources, try and explain what typing meant, but there was never any effort by me to mislead a family.
So I want to just pick up something that is suggested. I'm not going to put it on the screen, but I'll just read it out. There is within paragraph 65 of that document, that submission, the suggestion that if we turn to Cryptococcus as an issue, that at the time you were speaking to this family in September, that in January they would have heard you connect the Cryptococcus to the plant rooms and to pigeons. Do you think it's possible they would have heard that?
Sorry, which family is this?
The same family who we were just talking about.
Possibly. So at the time, myself and Brenda Gibson were speaking to families. I would go down to her clinic. I can't remember if it was a Tuesday or a Wednesday morning. And at the time of the Cryptococcus, we were trying to communicate to all the families. And what we would do, we would bring families together into a room. It wasn't a great means of communication, but we had to get round so many families in an outpatient setting. So I think we had 3 or 4 sort of lots of families that we delivered the same information to at the time. They were obviously very concerned because although they were attending the outpatient clinic, sometimes these patients would be admitted to the ward. So between us, we gave them an update on the investigation. But again, it was open and transparent and basically telling them what we had found and what the line of investigation was and what the relevant control measures were.
If you told them in January, late January even, that there was a hypothesis that there was a connection between the Cryptococcus and the plant rooms, how do you respond to the suggestion that in some way that was improper because the connection between the plant rooms and the Cryptococcus had been excluded by then?
I didn't say there was a definitive collection. I would have run through the hypothesis. Families were asking a lot of questions. Families wanted to know what we were doing, what we were investigating, and to the best of our abilities, myself and Brenda Gibson, based on the information we had, were open and transparent in response to those questions.
What do you say to the idea that by the end of January, the hypothesis of a connection between the plant rooms and the Cryptococcus cases had been excluded?
Not by the end of January. Dr. Hood was still investigating that hypothesis, and several months later himself was writing to Marion Bain to complain about the fact that that had appeared at a board meeting in minutes.
Thank you. I'd like to turn back to the topic of chilled beams. I've got the impression that I need to ask you some questions about when chilled beams were an issue. So, is chilled beams and the leaks or condensations from them, water coming from them, is that an issue of 2019 or something that had its gestation earlier?
Oh, much further back. I think around 2016 reports were coming in of leaking chill beams.
What was the response from the Estates Department at any point to the idea that there could be leaks from the chilled water circuit in the chilled beam system?
That was something that came up at the IMT in 2019.
So this is in early 2019 or in the summer?
So it's, the IMT, the gram-negative.
The gram-negative one,
so, right. There was a leak from a chilled beam reported from a family. The child's sock was wet and the mother noticed that and they noticed water dripping. I was at another meeting off-site, so I asked Christine Peters to go and look at the area on my behalf, and she went up and had a look around and she took photos. And it's very clear from her photos that there is a drip coming from a pipe. So there's not condensation, but the pipe work above. And there was water on the floor. And what she did is she swabbed both And from those swabs, we grew an unusual organism called Pseudomonas oleovorans, which tends to be found in sort of cooling agents and lubricants. Looking back at that organism, we'd only in our laboratory seen one in the previous 5 years from an outpatient sample. So that to us was fairly conclusive that it was leaking pipework onto the floor. We were told that leaks could only come from the hot, and that, well, not that they couldn't come from the hot, they would evaporate immediately, but the cold, there wouldn't be any leaks from the cold, that couldn't happen.
And did you eventually obtain some information about this from Colin Purdon in August of 2019?
I believe I did get an email from Colin Purdon, but there was another estates officer on the unit with me at one time, and I think Kerr Clarkson may have been there. And this estates officer gave me a much more detailed description and said to me, yeah, you can have leakage from the cold.
Was there anyone suggesting that you couldn't?
It was suggested at an IMT by the Director of Facilities.
How often were you finding water that you thought might have been a leak from the cold circuit?
So I'm only really aware of that occasion in that room. I have some recollection of back in 2016, potentially there being an issue in Ward 2A rather than 6A with loose connections, but I would have to check. And I think Mr. Powry was involved, and I think it may have been around the time of the aspergillus. It may be in those minutes.
I think there is some evidence around that, but so I'll move on. What I wanted to do was to just explore the credibility of a suggestion that leaks from the chilled beams, or indeed condensation of them, could have any pose a risk to patients that was material. So if we take condensation first, by this point the cleaning of chilled beams frequency has increased.
Yes.
To every 6 weeks. From 3 months.
I think so at that point, yes.
So realistically, if you're cleaning the chilled beams slightly less often than once a month at 6 weeks, do you realistically have any risk of infection from water condensing on them and dust?
I mean, dust gathers very quickly. Dust gathers on surfaces very quickly. You wouldn't normally leave a surface in your own home or work office for that length of time without wiping down, I think, and finding dust. So yes, there is potential. I think the 6 weeks is really because of resource issues, difficulty accessing rooms. Chilled beams are positioned above a child's bed, so you have to have an empty room. So it's really impossible to have a chilled beam as part of a normal domestic cleaning schedule because it's so disruptive to actually do it. In an ideal world, in a hospital, all these surfaces would be getting cleaned daily and they would be dust-free daily. So I think 6 weeks was a sort of pragmatic approach to deal with a challenging area to clean and gain access to.
And in respect to the chilled water circuit, are you saying that there is any, did you see in your mind, a connection between the chilled water circuit and risk of infections, given that particular microorganism that Dr. Peters found was never found in a patient?
I suppose it's a bit like a water system. When you find one organism and the environment is right for one organism, there might be others there, so it's conducive to others. So there may be something in that system that is promoting microbial growth. But we didn't find any evidence of anything else at the time in that system.
How would you react to the suggestion that the idea that there is a link is purely speculative, therefore?
I think, again, it goes back to plausibility and probability and all the risks, the disadvantages of environmental sampling that I've discussed. So the chilled beam is quite a broad surface area. We were taking a very small swab. We were swabbing a relatively small area of that. I've talked about adherence of bacteria, difficulty getting it off the swab. We weren't swabbing them on a daily basis. There was limited laboratory capacity. So just because we didn't find an organism doesn't mean that it wasn't there. And I think if you sort of strip it back to just say there were no infections in chilled beams in a ward with immunosuppressed children, with condensation, with water drips, that isn't a safe environment, regardless of whether you have infections or you can prove links.
I'll come back to that in general when we get to the end of this year, as it were. What I'd like to do now is to turn to the period up to and including your removal as IMT chair. So I wonder we can just recap. So we've looked a number of times at the IMT of the 14th of August. In fact, it may be bundle 1 may show it now if we put it up. Bundle 1, page 343. Was there anything unusual about this IMT meeting compared to its predecessors?
Yes.
What was that?
The atmosphere from the very beginning.
And in what way was it unusual?
There was challenge right at the very beginning about the minutes from the previous meeting in relation to the name of the chief executive being documented in the minutes.
And so this is the idea that if there's to be a further decant, it'd be minuted that the chief executive would make the decision, and some people wanted that removed.
Yes.
Who wanted that removed?
The director of facilities.
Is it normal to name an office bearer in a minute who's going to make a decision in IMT minutes?
Yes, I believe so.
When the previous decant had happened, who had actually made the decision?
The chief executive.
Would it not be fairer to say that it was this water review group that met of about 8-10 people and made a decision instead?
So I wasn't at that meeting, so I don't know what took place at that meeting, whether it was a group decision or whether ultimately the chief exec made the decision. I don't know.
And what I'm wondering is, how did her name get into the minute? Why was the discussion at the meeting around the idea that the chief executive would make the decision rather than some executive group would make the decision?
Somebody must have named her at the previous meeting.
You don't remember who?
I don't recall.
But anyway, it was an unusual meeting and there was challenge. Anything else about it that stands out now, looking back on it?
So when we came to discussing the epidemiology, I'd brought 2 colleagues along with me because by this point I was being significantly challenged around the epidemiology. And I wanted to bring Kathleen Harvey-Wood and Dr. Christine Peters, who'd produced that previous report, to the meeting. Kathleen Harvey-Wood had obviously decades of experience covering the old York Hill Hospital, so she had insight into that. And Christine had obviously produced the report with her, but also I wanted Christine there because the chilled beams hypothesis was being contested. So those 2 individuals were present. When we talked about the epidemiology, Kathleen was talking about the data and how it was unusual and it wasn't similar to what they'd seen in York Hill. And she was challenged by one of the individuals in the room around what she was saying. And
given they may have been a witness, whom?
Dr. Deegan.
Right.
And he said to her that children splash in muddy puddles.
But in terms of the epidemiology, how did he challenge her?
Sorry?
In terms of the epidemiology, how did he challenge her?
He was referring to Ian Kennedy's report, talking about how these were rates comparable with York Hill, that the organisms had been seen before in York Hill. But obviously Kathleen had had decades of experience covering that unit, and that wasn't her view.
After this meeting, did you hear from any member of the infection prevention control team about the IMTs and how they were to be run in the future?
So around 2 days after this meeting, I was at a meeting with the infection control team and Sandra Devine stayed behind to talk to me. She referred to this as being a difficult IMT and it must have been difficult to chair. And she said to me, could you please think about what support you might need around future IMTs? And at the time, I expressed concern about the time that we were taking to go through minutes. So I asked if the meetings could be recorded to make that process easier. And then I referred to the sort of narrative that I was a lone voice in the room around epidemiology and that I would find it really useful to bring microbiology colleagues along with me to future meetings. And I believe I also discussed perhaps an operational chair because we didn't have control of the environment at that time, we were once again thinking, do we need to decant again? So I remember saying maybe I need a second chair, and we'd done that previously.
So how would a second chair work?
So how that would work is, because this was still very much an active infection control investigation, I would lead the first part of the meeting. So basically the standard IMT agenda, right down until the bottom when it gets to contingency planning, and then I would hand over to them.
And what would they then do?
They would take the members of the meeting through the contingency planning and develop actions for that.
So if we, for example, just look at this IMT because it's in front of us, effectively, would it be somewhere around page 337 in this minute that you would get a switch over? 347, sorry. There should be an action point. Sometimes you get action points. This isn't a bad example. I shouldn't have picked this one. But we've seen IMTs that have an action point here.
Yes.
Would it be somewhere in the action point that you would hand over to the operational chair?
Probably not. The actions would be pulled together all at the end. So it's probably likely to come maybe just before the communication section or just after that.
But around about the time of what we're going to do now.
Yes.
Right. What else did she tell you? You can take that off the screen.
That was all she told me that day.
Would you say that you volunteered to a change of chair?
No.
Did you at that meeting agree to be replaced?
No.
No. Did she say anything about a meeting that you'd been invited to on the 20th of August?
No, she didn't. Our conversation was in the morning, and then this invite came after that.
Well, let's look at that. It's Bundle 14, Volume 2, Document 144, page 568. 568. Thank you. We've seen it in a number of different versions, but this one, is this the invitation that you received at 11:35?
That's correct.
What's this an invitation to?
It was a meeting to understand what additional support was required for the IMT. So I've talked about issues with the minutes. There was also issues with getting rooms in the hospital. It was proving difficult to get the same room or a big enough room. There was also, it was a very stressful time for staff, particularly nursing staff, and I think they were in need of more support, which I think is why Margaret Maguire is on that list as the Director of Nursing.
So you're confident that although this email doesn't mention IMT, it is about the IMT?
Yes.
Right. Did you intend to attend the meeting?
I did.
Before we get to the meeting that happens on the 20th, I'd like you to look at another email. This is an email sent on Monday the 19th of August. Bundle 14, Volume 2, Document 155, page 601. Do you remember getting this email?
I do, yes.
Is this responding to somebody who we now know to be Dr. Peters, but of course wasn't known then, whistleblowing about the previous meeting on the 14th to HPS?
Yes.
When you received this meeting, did you know that Dr. Peters was the whistleblower?
She had told me that she'd contacted HPS.
So you knew it was her, effectively?
Well, yes, I'd worked out it was her, but she didn't refer to it as a whistleblower. She said she was going to contact HPS.
Right. Now, what are you being asked to do by Dr. de Castiga?
So I'm being asked to participate in an investigation led by Dr. de Castiga, but with input from an HR director, and she wants to get my perspective on the issues that have been raised by Dr. Peters.
And did you reply saying you'd be happy to meet on those dates?
Yes.
Now, if we go to the, you weren't able to make the meeting on 20th of August
Correct.
because you had a respiratory virus.
Yes.
Did you tell Sandra Devine you weren't going, or anyone else?
I told Dr. Peters, who is my line manager and who was my point of contact for any health-related issues.
And are you assuming that she would have passed that information on, or you don't know?
She would do that automatically, yes.
Right, okay. Let's look at the minutes of the meeting, which is Bundle 6, Document 22, page 70. So when did you receive these minutes?
I think I received them a few days later.
Would it have been before or after the IMT of the 23rd of August?
Before, I think.
Before?
I think. I'd have to check.
Well, it may matter, but we'll go on.
Okay.
What was your reaction to reading these minutes?
When I read them, I was quite upset because there was reference to behaviour that I didn't recognise, and that
Behaviour by you,
well, it was microbiologists plural.
right?
And there was a suggestion that there had been a culture of non-team working in this IMT. It suggested to me it wasn't just about one meeting, but it was plural microbiologist behaviour.
And the only microbiologist who's going to all the meetings is you.
Yes, and nobody had told me or given me any feedback about my behaviour. Because the IMTs were quite complex, were challenging, I was asking people for feedback. I would say, did I chair that okay? And I never got any negative feedback from anyone at the time.
If we go on to the next page, we see some actions. That's why it may matter when you received it. It's proposing to change the IMT chair to an experienced public health doctor or an ICD for another area.
Yes.
Ultimately, it was a public health doctor, but an ICD for another area, what should we mean from that? Another area in terms of within the health board or another health board?
It would be within the health board.
And so, given the small number of sessions, we're looking at what handful of people who meet that description?
Yeah, at that time there would only be 2 or 3 people.
Right. And then the pre-meeting section. Who are the key members being discussed in the section at the end about pre-meetings at item 3? I mean, you weren't there, but who do you read that to be in the context of the minute?
The people attending the pre-meetings.
No, that attended the pre-meetings, yes.
So regularly would be Sandra Devine, Scott Davidson, Tom Steele, Kevin Hill, myself.
Is this in effect the pre-meetings that you'd had before?
I believe so. We'd already had pre-meetings before this meeting.
Right. Could it be that other members of the IMT just didn't know about the pre-meetings?
Yes.
So before this meeting took place, other than Sandra Devine, had anybody else, and Dr. de Keesteker's email, had anybody else communicated with you about the IMT and how it was operated?
No. Well, actually, Sandra Devine did speak to me on a second occasion, the day before this meeting.
Right, and what did she say then?
That was the Monday morning, and she said to me, I'm really sorry, but you'll have to give up the chair. She said that everybody, and I mean everybody, said the meeting was terrible, there was no team working, and at that point she informed me that Scott Davidson would be taking over.
So this is before this meeting?
This was the day before this meeting.
So the meeting happens, you're not there.
Yeah.
And the meeting, this is on a Tuesday?
Yes.
Right. Between this meeting on the 20th and the IMT, which is therefore on the Friday,
yes.
Did anyone communicate with you about the outcome of this meeting?
No. When
you are arriving at the IMT, at that moment, do you know you're not going to be the chair?
Yes.
Right. Do you have this minute?
Yes, I do.
Right. When you see, is there a pre-meeting happening when you get there?
I was actually invited to the pre-meeting by Sandra Devine. She phoned me to say there would be a pre-meeting, but because I'd been on days off sick, I then came back and had to find results for the IMT, so I didn't get to the pre-meeting.
But the pre-meeting ran on, we understand, beyond the start of the meeting?
Yes, so I was outside at that point.
You didn't think to go in?
No.
Why not?
I'm not really sure. I think I just got there at the time that the IMT was due to start, so I just waited with everyone else outside to go in.
And who was inside the room in the pre-meeting?
Sandra Devine was there. I think Chris Deegan was there. Amelia Crichton. Possibly Tom Steele. Senior management from RHC. I can't remember exactly who. In the corridor, there were clinicians, myself, and Annette Rankin from RHI.
So before we go into the IMT itself, do you consider that the process conducted to remove you as the chair met governance standards, as I think Alex Rankin's about to ask when we get into the meeting?
No.
Why?
I didn't feel that there was adequate discussion with me about removing me as chair. I wasn't really given sufficient feedback as to why I'd been removed as chair. In fact, in the meeting, I was given several other reasons from Sandra Devine, including being off sick, including the need for support. So it wasn't clear to me exactly why I was being removed as chair. I think perhaps a more appropriate approach would have been to discuss a deputy chair with me, perhaps a microbiology or ICD colleague. But nothing like that was discussed.
Do you consider the process that had been done to replace you as chair to be fair or not?
No, I didn't consider it to be fair.
And for what reasons?
I didn't feel it was fair for senior staff, some of whom had never been in an IMT, to be having a meeting where they were discussing the behaviour of myself and others.
When we get to the meeting itself, if we can go back to the IMT bundle to page 348. So this is the minute. Now, I appreciate that there is a point later where Annette Rankin challenges the minutes and makes some suggested changes. I think these might be incorporating some of her changes, but not all of them.
Yes.
But in general terms, is that big paragraph at the beginning, I mean, broadly right in terms of the order of events, in that people ask Dr. Crichton why she's chairing the meeting and not you?
No, it's not correct.
So how did the meeting go?
I had requested changes and the changes are not in this minute.
So if we put that minute to the side for a moment, just focus on what you remember. You arrive in the room, you all sit down, what happens?
I remember seeing Annette Rankin and Brenda Gibson sort of whispering to each other. And then they asked why Amelia Crichton was chairing, why there was a new chair.
Could it have been Annette Rankin who
I
asked?
think it was Annette Rankin, yes, who asked. Sandra Devine said that first bit, that she'd had a conversation with me and it was about me having a chance to review the incident.
Is that true? It's true that she had a conversation with you, you've already said that, but did she have a conversation regarding the complexities of chairing this meeting and being an active participant?
No.
Is that true?
No.
Did she have ever did she say, well, did she say that in the meeting?
Yes.
Yes, but it's not true. Did she say in the meeting that in principle you were in favour of another chair?
Yes.
And is that true?
No.
But you are in favour of an operational chair joining you?
Yes.
Is that a distinction that was made clear at the time?
Yes.
No, at the meeting was it made clear?
Oh no, not at the meeting.
Did she say that this conversation was informal and no decision was made at the time?
No, because she told me that Scott Davidson was chairing the meeting.
But did she say that to the IMT at the time, on the 23rd of August?
No.
No, that's not a fair recording of what happened.
No.
Right. Did she say to the meeting that she informed that in Dr. Inkster's absence this week, and to ensure that the meeting went ahead, she had contacted other ICDs, but because of the complexity of the meeting, they did not feel they could chair?
Yes.
Is that correct? From what you know?
I am aware that she did contact Dr. Valaraki, my colleague.
That wasn't perhaps the point I was focusing on, which is it a reasonable inference that the reason Sandra Devine contacted other ICDs was because of your absence? Why would she have contacted other ICDs? What would have been her reason?
It would have been to get another chair.
And we've already discussed the penultimate sentence, the last two sentences with Annette Rankin, so I won't go over them with you. No. How did the rest of the meeting go after this introduction?
It was a bit tense because actually what these minutes don't state is my reaction to what I was being told.
And what was your reaction?
I informed the group that I had been informed that the meeting had been dreadful and everyone felt it was dreadful because of my behaviour and the lack of team working.
And did you go on?
No, I stopped at that. I stayed in the meeting, but I stopped at that.
Did anyone react and say that's not true, or that's terrible, or you're an awful chair, or anyone respond in any way?
No one responded.
Right. Eventually, did anyone who was in the meeting back on the 14th of August comment on your observation that you've been told you were a terrible chair?
Yes.
Who was that?
Annette Rankin and Brenda Gibson.
Right. What did they then tell you later?
That I hadn't been a terrible chair, that I'd chaired the meetings really well, and that the meetings had been difficult and challenging, but not because of me, but because of other people.
Now, in the terms of the substance of the meeting, what then happens that's perhaps important? This is your last IMT you attend?
Yes.
Yes. So, is there on page 350 a report of Dr. Kennedy reporting on his epidemiology report?
That's correct.
And you suggest you produce figures from Great Ormond Street?
I do.
Why are you suggesting figures from Great Ormond Street?
So Great Ormond Street, at the time, were publishing an annual report of all infections in the Children's Hospital, and that was quite a useful resource. And I had accessed that. There were several years of data, and I was particularly interested in the rare and unusual environmental organisms that they were seeing, because I was being told that this was, we find these organisms in this patient group, this is no different from York Hill. So I was very interested to see what Great Ormond Street's data was showing. And I think the particular report I looked at, I think there'd been one Stenotrophomonas that entire year. It was a very different picture in relation to their epidemiology. It was the organisms that you might expect patients to have, those endogenous organisms like E. coli, coagulase negative staph, streptococci, and very few environmental gram-negatives. And I suggested that perhaps Great Ormond Street could come up and do a review, which would involve looking at our data, but also would involve looking at our children's ward. And there were two consultants there that I was aware of that I felt would have very valuable input if we were to invite them up.
And how was the suggestion received?
Somebody said that it wasn't a viable comparison because we were in a decanted ward.
Well, why would that be true?
I don't believe that's true because it's the same patient population aside from a handful of bone marrow transplant patients as 2A was.
So after the meeting, can I ask you to look at Bundle 27, Volume 11, Document 20, page 99?
Just before we leave the
Yes, of course.
Mr.
Back to
McIntosh,
the
it's
minute,
entirely my fault. Could I just confirm the points on which Dr. Inkster said, we're looking at the first paragraph under welcome, just the points where Sandra Devine is reported as having said something, and whether Dr. Inkster accepts what.
Or shall I just
she
go through
said
line by
being-
line, Bill?
Yeah, I would be grateful because, quite frankly, I didn't keep up with the distinction of what was said
Yes.
and what was accurate.
Well, I'll do it in the traditional manner. So what I'm going to do is I'm going to identify each sentence and ask you whether it was said, and then whether it's accurate. And there's a distinction, Dr. Inkster, I think. So, in the first sentence, the distinction you draw is it wasn't the group, it was Annette Rankin.
Yes.
But otherwise, is it something that was said?
Yes.
Right. You are recorded, the next sentence, Dr. Inkster informed the group that she will no longer chair the meeting. Was that said by you?
Yes.
And is it true?
That I was no longer chairing the meeting,
Yes.
yes.
It starts off a bit strange, but we'll
Yes.
get into the pace of this. Then Dr. Inkster said she was asked to demit the chair. Did you describe it that way? Sorry, was that said first?
It was said, no, I wasn't asked, I was told to demit the chair, and that's when I gave the feedback about the behaviours and everyone saying the meeting
So
was
that's not
difficult.
what was said.
No.
Is it true?
That I was asked to demit?
Yeah.
No,
No.
I was told.
Then we have Sandra Devine said she had a conversation with Dr. Inkster regarding the complexities of the chairing meeting and being an active participant. And that in principle, Dr. Inkster was in favour of another chair. However, this conversation was informal and no decision was made at the time. Is that sentence something that was said by Sandra Devine?
It was said, yes.
Is it true?
No,
Why is it not true?
because she told me that Scott Davidson was going to be chairing.
So therefore no decision was made.
Yes.
Right. Sandra Devine informed the group that in Dr. Inkster's absence this week and to ensure the meeting went ahead, she had contacted other ICDs, but because of the complexity of the meeting, they didn't feel they could chair. Was that said by her?
Yes.
Is it true?
Yes.
What is the reason of the complexities of the meeting? Is the reason that in Dr. Inkster's absence this week and to ensure the meeting went ahead, she had contacted other ICDs? Was the reason she contacted people because you were absent?
Yes.
Okay. And then the last two sentences, was that said or something very similar to it said?
I think that was said.
And is it true?
Yes, that's true.
Right. And the last sentence, is that true?
Sorry, where are we now?
This is also in keeping with national guidance law.
Yes.
Right. Was that said?
Yes.
Thank you. Does that assessment?
I'm grateful. Thank you.
Well, what I want to do now is just look at an email in Bundle 27, Volume 11, Document 20, page 99. It appears to be a series of emails, but I want to go back to the bottom of the email. So if we go on to page 101, page 101, please. So this appears to be an email from Annette Rankin, which is given evidence about. We'll get the date in a moment. And you see 4 lines from the bottom. NHGGC has replaced the IMT chair with the from the lead ICD to the Deputy Director of Public Health.
Yes.
Now, firstly, did you receive this email?
I did.
Let's go to page 100. We see at the bottom it was sent by Annette Rankin on the 23rd of August. We have a response from Sandra Devine at 5:11 on the same day. Did you receive this email?
Yes.
Now, let's go through this and work out whether it's accurate to your understanding. The first sentence, Chair agreed to be replaced in order for her to have time to review incident results and actions. Is that accurate according to your recollection?
No.
Is it consistent with the terms of the minute of the meeting 20th of August?
Yes.
Were you replaced in order to review the accident? Review the incident?
No.
No. Other ICDs in the site were asked to chair and declined. Is that true?
That's true.
Yeah. National guidance confirms it's appropriate for a CPHM to chair an IMT. Is that true?
Yes.
Right. Let's go to the next, your reply, which is at page 99. What did you reply at 5:25 that evening?
That I did not agree to be replaced to review the incident results and actions.
And then what did you say?
I'm highlighting that I was asked to demit due to the feedback from everyone that the meeting was difficult and that feedback was not corroborated by the senior clinicians, HPS or the microbiologist present.
Are you aware, and of course you'd only be aware if some of them had told you, but have any of these senior clinicians, HPS or microbiologists, told you they were consulted by Dr. De Case-Decker or any of the senior managers about removing you before you were removed?
No.
And we have the minute of the IMT, the minute challenge by Annette Rankin, which is, just for completeness, more for my colleagues than for the transcript. It's in Bundle 27, Volume 12, but I'm not proposing to go to it today. How did you feel after sending that email at 5:25 on the evening of the 23rd of August?
I guess very upset.
This is the worst question for lawyers to ask. Why?
Because I didn't recognise the behaviour that people were reporting about me. Like I say, I was always someone that was seeking feedback because it was a difficult, complex incident. And for me, I was relying on, I suppose, peers, senior clinicians, RHI, microbiologists to give me that feedback. And I'm sure that they would have told me if my behaviour had been difficult or as described. And I also felt that I'd been chairing this IMT process for a long time with many senior directors in the room. And I was puzzled and upset as to why none of them felt that they could have taken me aside and talked to me about my behaviour or the promotion of a toxic culture or however it was described, because I would expect a senior clinician to be able to do that and to give me the feedback and allow me to reflect on any behaviours and change them.
So I suppose one way of analysing this is to ask you this question, which is, looking back on the period from, say, the start of the water incident until the 23rd of August in 2019, so that's nearly 18 months. As far as you see it, did your way of changing IMTs change?
No, I've always stuck to the same process from way back in 2009, the way that I chair an IMT and conduct a meeting. Nothing had changed from my perspective.
Had the situation you were investigating changed?
Well, these were very complex incidents. I would say the most complex incidents of my career to date. So in terms of complexity, yes. But also the makeup of the IMT had changed. So previous IMTs had not had the same representation from senior management. Usually there might only be one manager present that would then communicate with the rest. But the makeup of the IMTs had changed significantly for me.
And does this go back to the conversation we had yesterday when you were looking at the executive control group of people reporting back what happens to your IMT before even you've managed to do so? In a very, very broad sense, was the IMT of the summer of 2019 any more complex than the water incident of 2018?
No.
If you had to, seems a ridiculous thing to ask, but if you had to rank in order of complexity all the various IMTs we've been looking at, what would be the sort of top three most complex IMTs that you dealt with in the new hospital?
The water incident would be number one.
Right.
Cryptococcus would be number two. Are we just talking about the new hospital?
Yeah.
And trying to think. Number three would probably be the 6A gram negative.
The summer of 2019.
Yes.
And it then comes that you resign
Yes.
as lead ICD, and you do that by a letter, which I think you sent on the 2nd of September.
That's correct.
Let's look at your letter, which is Bundle 14, Volume 2, Document 151, page 579. So the letter's undated, but am I thinking this would have gone as an attachment to document?
Yes, to an email, yes.
Right. Now, we can read this, and we have read it, and we'll now read it again before this inquiry is concluded. But from your point of view, what were your reasons for resigning, in summary?
So there were several. In summary, I felt that the IMTs are becoming really difficult. I felt that I was being undermined, challenged. My views were not respected. I think I felt like every day was a battle to be heard. I just didn't feel I was being listened to, particularly around the epidemiology. I was having to try and send published papers to sort of back up my argument. That was new for me. So all sorts of issues around the IMT. The other reasons were I had concerns about duty of candour with regards to patients. I was really concerned about what was being communicated to families. I'd had obviously the meeting with Professor Cudahy, but I I was finding it really difficult at that point to communicate with families because there was this divergence of opinion in the IMT. And I was finding it increasingly difficult to give families the answers that they wanted and what investigations the IMT would be undertaking, because there was this split view. So the communication with families was a concern. There was a lot of other stuff going on that I've listed there, issues with payroll, how I was being paid, issues with how sick leave had been managed, issues with changing to my reporting structure, a lot of I think irritation expressed at times by Sandra Devine because sometimes I wasn't present at meetings, but the reality was that my diary sometimes had 3 meetings at the same time and I had to prioritise, so the workload was an issue. And then the last reason...
Well, I'm not going to go through the health issues on the next page. I think we'll
That's
not put
fine.
them on the screen. But there was that as well.
There was that.
Right. So what I want to understand is how this resignation, as it were, the reasons for, I'll take it off the screen now, compares in a sense to your, I suppose it could be called a threatened resignation from 2018 when you come back from sick leave and they've restructured the reporting lines. Are there any themes that cross across the two?
I would say that the culture is the theme that crosses the two, because I had concerns about the culture when I came back from sick leave in 2018, which I've described, and my initial attempt to resign in 2015 was also related to the culture. So I think that is the underpinning theme of my resignations, was the culture.
And you received a response from Dr. Armstrong, which is Bundle 14, Volume 2, page 561. Sorry. Now, when you received this, do you think the letter is a sort of fair response to your reasons for resignation?
Could we move to the next page? Sorry,
Of course, yes.
I felt in this letter that rather than simply respond to the issues, there was, reading between the lines, perhaps some criticism coming back to me, particularly around the 3rd paragraph about effective team working, people being treated fairly, skills and experience respected, and around collective leadership and decision making. And it felt to me that she was criticising me on those aspects, which I suppose is similar to the output from the Linda de Castaker meeting and the behavioural issues and lack of team working.
That's the meeting in March with Professor Steele?
No, Linda de Castaker's investigation.
That comes later?
Yeah.
If we look backwards from here, this is on the 5th of September. Before you resigned, had you had any communication from Dr. Armstrong since the IMT of the 14th of August?
No.
Did she speak to you before she sent you this letter?
No.
So are we to infer, does she know that you've got a copy of the minute of the 20th of August?
She would, because she was included in the distribution list for that.
When did you discuss with her, when did she discuss with you, the need for effective team working where all members are treated fairly and their skills and experience are respected?
I don't recall her ever discussing that with me.
Did you feel treated fairly and having your skills and experience respected when you resigned?
No, absolutely not.
Looking back at these events from 5 years on, why do you think you were replaced as the chair of the IMT?
I think because at that point, organisational reputation took priority over patient safety. And I think perhaps where that IMT might have been leading was towards potentially another decant. And I think that was unpalatable to the organisation. And I think the didn't want me involved in the IMT anymore. So by removing me as chair, that sort of weakened my position, because as chair, you can direct the investigations of that IMT and you're the person pulling together the consensus. So I'd be in a much weaker position in the room. But I think it also relates to the fact that I had requested microbiology colleagues to come along. And that would mean that I was no longer a lone voice or out on a limb, that I would have support in the meeting. And I do think there was particular concerns around the fact that Dr. Peters was one of those colleagues.
In a sense, because she was known to them to be a whistleblower,
Yes,
you were being associated with her.
yes,
You're definitely associated with her now, aren't you?
absolutely.
Looking back on those events from 5 years later, do you think your resignation as lead ICD was inevitable? If we'd started the year, if we'd actually looked back at the events with hindsight from January, do you think that was an inevitability that you'd be resigning by the end of
From
the
January 2019?
19, yeah.
Yes.
Or why do you say that?
Because I think there was a turning point for me. I felt that the water incident was dealt with very well, very effectively. Everyone was on board at all levels in the organisation, and I think there came a point with the cryptococcus that there was a shift where this organisational reputation predominated, and I felt that that just became stronger and stronger as time went on.
What I want to do now is done what we've done twice before and look back at the situation as it obtained on the 23rd of August and ask, looking back at then, knowing what you know now, however, and looking back only at Ward 6A, what is your opinion as to whether there was a link between patient infections being seen in that first half, 2/3 of 2019, and the water and the ventilation systems of the hospital taken together?
I believe there was a link. We were seeing similar organisms to what we had seen in 2018. We knew in the autumn of 2018 that 6A was not the safest environment for patients. We knew that there was risk associated with that environment. It was supposed to be a temporary decant only. It was never a long-term facility for those patients. Whilst the patients were in the ward in 2019, we encountered several environmental risks, which included the water leaking from the chilled beams, exposure of children to unfiltered water elsewhere in the building. We also had a series of water leaks on the ward. So I think we've spoken about the kitchen, but there was also a leak from a corridor and a leak into, I think, one of the prep rooms. And we'd had historical issues, obviously, with the showers in that unit. So we also had the problem with the ventilation and the low air changes and the pressures. So it was never a long-term solution. It was with environmental risk at the time of decant, and I do feel that that was a contributing factor. And I think if we follow the epidemiology, so the epidemiology just doesn't stop when this IMT is closed down. So if we follow the epidemiology over time, and I can take you up to the point that I left last September, post-refurb, post-moving the patients back, dealing with all these environmental issues, the line is almost completely flat in terms of infections.
So what are you saying, what conclusion do you draw from the fact that there's almost no infections now in the New Schahalian?
That the built environment in Ward 6A was a factor. Ventilation, water and drainage.
Because in a sense, the biggest control measure of all was to replace Ward 2A.
Yes, so I spoke earlier about sometimes you need a drastic measure, like refurb or a new unit, and we'd undertaken that. And in my view, it's been effective.
I want to challenge you about a few things you said in that discussion. So I wonder if we can go to Bundle 7 at page 233. This is from the HPS October 2019 report that was produced, I think, a little bit after you resigned. Have you seen this figure before?
Yes, I have.
So Dr. Kennedy took some time over this, and he suggested that there is a distinct difference between the organisms identified in 2A, 2B in the summer of 2018 and the organisms identified in 6A, 4B in 2019. And I think he was even hinting at, perhaps he didn't go quite as far, is to say there's a similarity between the two right-hand columns, so between York Hill and 6A, 4B. And you did say you were seeing the same organisms. And so doesn't this sort of piece of work suggest that there was actually a change from 18 to 19 as the organism polyvariant or reduced in a sense?
Yeah, but I think we can explain that.
So how can you explain that?
Because see the more colours at the top there, these are more typical organisms that would be found in the actual water coming out of the outlets. And we had point of use filters in place.
So in a sense, that's why they stopped.
Yes.
And what would you, if you take the coloured ones off the top, what do you say about the difference between the second column and the third column on this figure 9?
They would look fairly similar then if you take the top off, I think.
There's a lot more in Terabacter. What does
Colours.
that tell you?
So that's the one I discussed. That is sometimes you might have a normal background rate for because it is a coliform, probably the third most coliform, but popular coliform. But Enterobacter is an opportunistic premise plumbing pathogen, and those levels of Enterobacter are higher than I would expect. I would expect within the infections in this ward to see E. coli and second to that Klebsiella, but particularly in the last column there, the Klebsiellas, there's only 3 of them and there's 3 times the amount of Enterobacter, and there's 16 the year before. And that to me might suggest that there is an issue with the drainage system in particular.
What would you say to the very broad suggestion that the fitting of the chlorine dioxide was, during the first half of 2019, having such an effect on the water system that it's the driving force of a reduction in infections, and that in a sense the biggest problem has been fixed by treating the water, and that that's something you didn't take account of?
I think, as I explained, outbreaks are multifactorial and they are multimodal to fix them. You're not going to rely on one control measure to bring an outbreak like this under control.
Dr. Crichton referred a lot to the epidemiology not showing there was a single source. Was there ever a suggestion in 2019 there was a single source?
I believe there's a report from HPS which suggests there's no single point source that I think has been misinterpreted.
In what way?
So a point source to me in a water incident might be a single outlet. So say, for example, in a treatment room, there's a tap that's contaminated and there are a series of patient infections as a result of that. So what you would see is a rapid spike in infections and a rapid decline linked to that one outlet. That's a point source, classical epidemic curve. And you would fix the problem and you wouldn't see any more infections. That's what a point source outbreak is. That was interpreted by meaning the entire water system, which is not correct.
Why is that not a point source?
Because those are multiple outlets, very complex systems with multiple different components. And if you look at the epidemic curve that we constructed, so you can get a lot of clues from an epidemic curve. A point source, which I can draw this, is a rapid up and a rapid down. What we had was a continuous source, so just continual infections.
Would this be actually illustrated in Dr. Kennedy's paper?
It possibly is, yes.
Well, let's have a look at what he's produced. This is why I suddenly, here we are. Page bundles 6, page 104 starts his 2019 paper. And I think he would like us to look probably at page 107 and then look at page 108. But we'll start at page 107. So he would say, well, this list is your list.
Yes.
And that's true. So is this the sort of curve you're talking about, or have I completely misunderstood?
It's quite similar to it.
Because
but
he would
not
point out
exactly
there's
the
a
same.
reduction at the end on the right-hand side after October 19. I think he did say that.
Sorry.
If it assists you, we're about 40 minutes from the end.
That would be consistent with a continuous source. with various peaks through that time.
Because if I understand his position correctly, and that of the way it was understood by Dr. Crichton, that the things that stood out for him on this chart are 3 effective peaks or groups of peaks. On the left-hand edge in late 13, there's some form of peak in the organism rate. In 2017, there's 2 peaks in the organism rate and the case rate. And in 2018, there's a peak only in the organism rate. And he thought those were legitimately significant, all 3 of them. But if I understand his evidence correctly, the general flow through time over that whole period was broadly consistent, and therefore we're back to background rates. I think he wouldn't quite put it that way, but I'm being a bit glib. But would you not accept that as a piece of analysis?
No, because again, it goes back to the point I keep making about the nature of the bacteria.
But these bacteria are the bacteria that you selected in 2018.
Yes,
so
but
why shouldn't we look at them?
Because these rare and unusual bacteria, we should not be expecting to see background rates. So a single case of these would be considered significant in terms of a contaminated water system, something like Cuprivadis or Delphtia acidovorans, that sort of thing. These aren't organisms that we would normally see in that patient population.
So I think you've answered the question I haven't yet asked, which is about how do you react to the epidemiology they were relying on. But I need to ask you how you react to the whole genome sequencing.
Yes.
Because at this point, I get the impression that whole genome sequencing was being actively managed as a reaction to infections. Yes. And that applies through the balance of 19 and into 20 and onwards. You're nodding again.
Yes.
If you're doing whole genome sequencing as an active project, as opposed to using historical samples, do some of your concerns go away, and therefore it provides an answer to the idea there's an infection link in late 19 and into 20 and onwards?
I think if you were doing an active project, it's going to depend on all those things I talked about before. So your sampling strategy at the time would need to be taken into account, and also the colony picks as well, which I've discussed previously, the need for 20 or 30. It goes back to those 2 things. So by all means, you can do whole genome sequencing at the same time as the patient cases, but you still need to have adequate sampling from your water and your drainage system, and you still need to be picking off the 20 or 30 colony picks to get any meaningful data.
So in effect, your answer to when is it possible to conclude there's no link remains the same. It's Suzanne Lee's 20 or something like that.
I mean, it's evidenced by other papers in the literature. It's not just Suzanne Lee's thoughts.
No,
but yes.
Now, after you resigned, you explain in your statement that you went to see occupational health, and you gave quite a lot of detail, and I'm not going to go through that in the hearing, but I want to understand a couple of questions. Did you want to go on sick leave?
No, I did not.
Did the doctors treating you consider that you needed to stop work?
No, because they were very keen, and I was very keen that I maintained as much of a normal life as possible.
Why did you end up going on sick leave then?
I didn't go on sick leave.
Why were people asking you to go on sick leave?
Yes.
And who was asking you?
When I first went to occupational health the first day, I was being referred for adjustments to my normal working day. But when I went into the room, I was told immediately by the occupational health employee that she was signing me off sick with stress.
And you didn't feel that was legitimate?
No, I had a physical illness, not stress.
Right. After you resigned as lead ITD, did Dr. Crichton, the new chair of the IMT, ever contact you seeking a handover?
No.
After you resigned as lead ICD, did the new interim ICD, Professor Leonard, ever contact you seeking a handover?
He did.
And when was that?
I think I volunteered information to him. I remember sending him some information, and I we had an infection control shared drive. I put lots of documentation on that for him. And I remember him asking me to come to a meeting with him, Annette Rankin, and Sandra Higgins from the laboratories to discuss drains and the hypothesis around drains and the routes of transmission and drain cleaning and that particular.
Did you go to that meeting?
I did, yes.
Dr. Deacon gave evidence that she got most of her information on the previous investigation from Dr. Kennedy. Would he be an appropriate source?
No.
Why?
Well, he wasn't the chair of the INT and he's not a microbiologist, and this is very complex microbiology and complexities of water and drainage systems. So while he will have some experience from a public health aspect, I wouldn't suggest that he would have been the most appropriate individual to speak to.
Now, there was then an SBAR on the 25th of August 2019 by some microbiologists based in, in fact, possibly all the microbiologists based in the Queen Elizabeth.
Yes.
Am I right in saying it's all of them?
I think one person was on sick leave or annual leave at the time.
But everybody who's around.
Everyone who was around, yes.
If we look at that, please, it's Bundle 4, document 41, page 165. Yes. Were you involved in drafting this?
I was.
And who else was involved in the actual drafting?
I think there was some input from Christine Peters as well.
Right. What was the, if we go on to the next page, you list various issues. Is it fair to say that this is where we find your state of understanding of matters the days after you resigned as the IMT chair? This is where we find what you think at the time.
Yes.
Right, so that helps us in
Yes.
speeding things up. So if we go on to the next page and the recommendations, you're effectively suggesting another decant, aren't you?
Yes.
Where would that have gone?
Well, we had started these conversations further back in January in relation to the cryptococcal incident. It was, I think, Dr. Armstrong's suggestion. And intermittently throughout that year, we had been discussing this, but nothing was really delivered in relation to that topic. I think had we put some serious thought into that in the January, we could have potentially, one of the things we'd considered was a mobile unit.
Yeah.
So you can bring in mobile units which can provide positive pressure rooms, negative pressure rooms, the sort of spec that we would require. And on hindsight, I think that might have been the thing to be pushing for back in January when we were starting to run into problems with that ward, and we had recognised that the temporary decant was going to be much longer.
So this is around the time of the CDU decant.
Yes.
I suppose with that recommendation, one thinks of Dr. Stewart's review from 2015, the one that you didn't see at the time,
Yes.
which contains at the end a reference to organisational political perspectives.
Yes.
Now, the version he gave for it is what I want to put to you, which is that he explained that his modern reading of it is it's a suggestion that you have to be realistic to what is achievable in an organisation, and that there's balancing between the different pressures on patients, and you can't just shut a unit because patients have to go somewhere, they need to have the procedures done. To what, if you apply that standard, firstly, is it a legitimate standard to apply? And secondly, is this idea of a decant in August 19 remotely realistic?
So at that time, I believe there was only very early discussion about the specification for Ward 2A. So sometimes these mobile units can be pulled together very quickly, maybe 2 or 3 months. So at that point, that may still have been realistic in the time frame. And just going back to your original point, we were dealing with the most immunosuppressed and sickest children in the hospital. So I think it is a reasonable request. And from my perspective, organisational reputation and politics does not come into that decision.
Thank you. I want to look at another SBAR of 7th of October 2019. That's the same bundle 4, but this time it's page 180. How did this SBAR come about?
I believe this is myself and Christine Peters continuing to highlight our concerns with the situation on Ward 6A, and it was possibly stimulated by one of the epidemiology reports.
Could it have been stimulated either by Dr. Kennedy's report or by potentially by the suggestion the ward was microbiologically safe?
Yeah, possibly. I'm not sure which one.
What are the core things we need to understand from this? If we go to page 181, why are you highlighting the issue of outbreak definitions in this document?
Because there seemed to be a view that because these were different organisms, that there was no outbreak. So there was a view held that an outbreak is only due to a single genus of organism.
So you have two within a certain time.
Yes, species of organism, sorry. So you say you have 2 Pseudomonas in a 2-week period, that would be an outbreak. If you had a Pseudomonas and a Stenotrophomonas, that would not be an outbreak. So there was a very clear view that an outbreak was a single case only. But we know from the literature and multiple other papers that that is not the case, and that outbreaks can be polymicrobial, particularly when they are linked to environmental organisms. So that is the point that we are trying to make there, that just because you don't have one organism causing one outbreak doesn't mean that you don't have an outbreak.
Does this go back to the email that we looked at this morning? I think it was this morning, it passes by. From you to Tom Walsh, which he copies to Sandra Devine, it ends up with Dr. Armstrong discussing the changing of the triggers in the summer of 2018.
Yes.
And does this reference back to your observation at the very beginning about DGC's infection control team being good at dealing with the known and the predictable?
Yes.
So which part of the national intervention, is it the case that an outbreak always has to be 2 cases within a certain period?
No, if you look at the chapter 3 of the National Manual, there are several definitions of an outbreak or an incident within that.
And you feel they were being too rigid?
Yes, because several of those other definitions would have applied at this point.
And if you go on to the next page, you discuss the CLABSI rate. I mean, I'm assuming the point you're trying to make is the middle third end of the second row, third line, that it's possible to have a reduction of rates while the outbreak's still going on.
Yes, because we were doing all this work around lines, and that was driving down those endogenous gram-positive organisms.
And that shouldn't mean that everything else is fine.
No, absolutely not.
Right. And I think we've already, well, I haven't discussed with you, what's your criticism of the use of SPC charts?
So, quite early in my career, I had a near miss of an outbreak because of a reliance on an SPC chart. So we had an outbreak in a burns unit, which looked perfectly under control, but in fact, we had a toxin-producing strain of the bacteria. And that led me to question the use of SPC charts a bit more than just accept them at face value. And it taught me to have an understanding of the nature of the bacteria.
What was the lesson that SPC chart wasn't showing you, as it were?
It wasn't showing me that there was an outbreak in the unit from
Because it showed there were infections, but not of that sort.
Because we hadn't breached an upper control limit.
Right.
So it looked perfectly well in control. So I hadn't had a great experience with SPC charts before this incident. I think, as I've said there, they are very valuable, and I have used them for organisms that we think are endemic. So that's where you have a low level all the time. So that's your background rate, where you expect to find a background rate. And these are organisms like Staph aureus, C. diff, MRSA. And I think the challenge with using SPC charts is you're dependent on at least 25 points of stable data. So those endemic organisms lend themselves well to that concept. The problem is if you have a contaminated water system, it's been contaminated for years, you've had infections as a result for years, when you're then constructing an SPC chart into 2018 and 2019, your baseline is elevated, and therefore your upper warning limit and your upper control limits are high. For some organisms which don't have any background rate, where 1 would be a problem.
Because those HPS SPC charts use the whole range of data to construct the mean, or the median rather.
Yes.
Right. We go on to the next page, onto 183 actually. I just wanted to ask you about why you've taken a particular approach in the rest of these graphs. They all seem not to have a denominator. They're simply counts. We'll just walk through so you can be sure of that before I ask you questions. So 183, if we go to 184, appears to be counts. 185 appears to be counts. 186 appears to be counts. 187 appears to be counts. And then we end up with some conclusions. Now, I want to just ask you about the use of count data, because I recognize that Ms. Harvey Wood's presentation used count data, quite a lot of her work, and then used percentage positive bloodstream infections as well. And Dr. Kennedy and Dr. Imrie have sung the praises of occupied bed days as a suitable denominator. You've referred to line days in the CLABSI paragraph we just looked at. And the inquiries expert, Mr. Mukherjee, has appealed that admission days are a useful denominator. I'll come back to that in a moment. But why are you presenting this in terms of absolute counts, rather than with some sort of denominator?
So the way this was put together was that all these graphs and charts are in fact Dr. Peters' work, and much of the commentary is mine. So I think I would have to defer to her to know exactly what she was thinking when she was putting these together.
But I can ask you the second question then, which is that if we're faced with the idea of comparing places, obviously it seems important to divide the number of things happening by activity. Where would you stand on the, or would you take a different view on the idea that between occupied bed days, admissions, percentage line days, percentage bloodstream infections, what do you think is it should be used as a comparator to understand, a denominator to understand these sort of issues across hospital sites?
So I'm going to take a very different view on this, and I'm going to say that I don't think comparing with other hospital sites was required.
Why?
Because we were meeting the outbreak definitions in the national manual. We had epidemiological links in time, place and person. We had the basic concepts of outbreak management fulfilled, and we put the relevant control measures in place, including the drastic measure of a refurb, and we have not seen, I'm not going to say any further cases, but very low numbers of infections still. I'm not sure how valuable it is to compare with hospitals that we know nothing about. So we know nothing about their built environment, their water system, their drainage system, their ventilation. In some cases, we don't really know the age of the site. Some of them might be substantially older. So I think the best comparison actually is the unit itself and what happens over time, and what you do if you plot all your control measures on the chart over time. And you will see initially that we control the water system with the point of use filters, and we can follow that chart, and there's a drop in infections. Then we have the spike with the drains, then we start to control that. Then we have exposure to unfiltered water, infections go up again, and then ultimately the control measure on that chart is the refurb and the move back to 2A, and then that line flattens. I'm not accustomed in all the outbreaks I've chaired in comparing different hospitals across the UK and different units in the country. It's not epidemiology that tends to feature in the hospital outbreaks that I've been involved with. We rely on those basic principles of outbreak management.
What would you say that it's, I'm not sure fair is the right word, but good use of resource or good public policy to conclude that a hospital, if someone was to do this, conclude that a hospital has unusual infections, has a problem that needs to be addressed, has a link between its buildings and environment, without comparing it with Great Ormond Street or Cardiff in the Vale or even York Hill in the old days? Wouldn't it somehow be ignoring a possible piece of evidence? Why is it not legitimate to think, well, we need to compare it with everywhere else, because otherwise we're wasting time or money or opportunity?
Children were very sick. Children were septic. Children were in critical care. Children died. I wouldn't consider that a waste of time or money.
What would you say to the idea that the fact that the warder was refitted is at vast, quite a lot of expense, 2A was rebuilt, was merely an exercise in the precautionary principle, and that one shouldn't infer from that any suggestion that there was a recognition at the time there was an infection between the water, linked with the water and infections.
No, I wouldn't agree with that. I would say that that was an essential refurb to bring an outbreak under control.
Do you think the people who made the decisions above your level in the board would accept that they made that decision because it was essential to bring the outbreak under control?
No.
Why?
Based on what I have read in relation to this public inquiry, based on a view that has been expressed that patients are bringing these organisms in with them from home.
I want just to pick up a few things before we have our break to see if there's any questions in the room. You have in your statement given an awful lot of detail about your reaction to the Oversight Board, the case notes review, the independent review, and you discussed at great length, a lot of infections that you became aware of while you were still a microbiologist until you left to your new job. You've discussed what you do in your new job. I'm not going to go through those in any great detail. We can read them. And of course, in due course, your own lawyer can make submissions. So I'm not going to go through those in public, but I want just to discuss a few things to do with the investigations that were carried out. They sort of dit around, so I hope you'll appreciate this. I'll try and get them in order. So the first thing is that you have given evidence that the day before the meeting that took place on the 20th of August, chaired by Dr. De Kistiker, to effectively decide on a replacement for the IMT chair, you received an invitation to attend a meeting in October to discuss what we now know to be Dr. Peters' whistleblow
Yes,
to HPS. Didn't you attend that meeting in October?
I did.
And did she produce a report?
Refused to.
Did she produce a report?
I think she did, yes, she did.
Did you ever see it?
I did see it, yes.
Given what took place at the meeting at the 20th of August and what the invitation email says, do you think she should have been investigating the IMT, given that she presumably made some decisions on the 20th of August?
No, I believe that would have been a conflict of interest.
Did you say that at the time?
No, I didn't.
Why not?
It's very difficult for someone like me to challenge someone so senior in the organisation.
You've also given a detailed narrative in Chapter 15 about your interactions with the Scottish Government.
Yes.
And we have those, and most importantly, we have your emails, and in due course we can put them to people. But one of the things that you discuss is a list of desired outcomes that seem to emerge from a meeting between you, Dr. Peters, and Jenny Copeland of NHS Scotland.
Yes.
Now, this is in Bundle 14, Volume 3, Document 187, page 63. And if we go on to the next page, we see a sort of table. Now, I recognise this was produced, I think, by Ms. Copeland.
That's correct.
To what extent should we consider it as a useful list of your desired outcomes at the time?
It is very useful, it's accurate.
Thank you. Well, we'll use that. I can set it off the screen. What in broad terms, taking the overarching sort of higher level view of this, what concerns do you have about the effectiveness of the work of the Oversight Board in respect of this appointment of the Oversight Board for this hospital, this board?
I think at the time my concerns were that it wasn't truly independent, so members from GGC were attending Oversight Board meetings. I was concerned about the final report that they produced in terms of accuracy of timelines and information that had been contained, despite me providing them with some information. There was one thing in particular I remember around the paediatric BMT, where I described to them the holes in the ceiling the first time I went there, and the dust and the risk from that. And I asked them why they'd omitted that, and they said to me that someone had decided it wasn't important, and that struck me as quite astonishing, that someone would think that holes in the ceiling and dust in a paediatric BMT unit was not relevant or important. So I did have concerns about how the information that myself and others were passing to them was being assessed in terms of the risks to patients.
A repeated element within this section is that you express concern that people within the Oversight Board and the Independent Review, and indeed I think I just did it myself a few minutes ago, thought that you were on sick leave at points after you resigned as the lead ICD.
Yes.
Why do you think this is important? At least, I mean, apart from that, I got something wrong and so my mistake. But why do you think it's important? It's something you need to draw out as an issue.
The reason I drew it out is I knew that the independent review in particular were trying to speak to me again. I was expecting that after the first interview. First interview was just a very vague overview of issues, and I knew I was going to have to go back. And when they approached the health board, they were told that I was off sick or not available. And it came up again during an oversight board conversation. I seem to recall someone who sat on the oversight board who knew me contacting me and saying, are you off sick? Because there was reference to that again. And I'm just speculating, but by saying that I'm off sick, it means I'm not around to be spoken to.
Now, a minor thing in your statement, hopefully it's minor. If we go to page 320 of the statement bundle, at paragraph 1041, you discuss a meeting which you describe as last minute with the expert panel of the case notes review. You describe them as Professor Mike Stevens, Professor Mark Wilkins, and Linda Dempster. Could you mean Gaynor Evans at that point?
Yes, I think that's a mistake on my part. Yeah.
And who was at the time clinical lead for gram-negative bloodstream infections at NHS Improvement?
Yes.
Right. Now, before we turn to before we have the break, I want to ask you about Dr. Walker.
Okay.
So Dr. Walker was appointed as an expert to this inquiry, and we've noticed that you've published a number of papers with him over the years.
Yes, I have.
What's the nature of your relationship with Dr. Walker, and have you discussed the events of this inquiry with him?
No, so Dr. Walker and I have never actually met Dr. Walker in person. I have corroborated with him on papers with another individual called Michael Weinbrunn. So we would have Teams meetings and we would divide up the work, and usually Mike would coordinate those and pull things together. Also, I have sat on the non-tuberculous mycobacteria group with Dr. Walker.
Which produced the English paper that you mentioned earlier.
Yes, but there were many members of that group, so that was a big Teams meeting. The other event where I was involved with Dr. Walker was a faculty that was set up to deliver education on healthcare water systems by European Society of Infectious Diseases and Microbiology, and it was held in Northern Ireland. It was a 2-day event. Both of us were speakers. I was aware at that time.
This is quite recently.
Yeah, this was just last year. I was aware at the time of Dr. Walker's involvement with this public inquiry, so he travelled to Ireland and delivered his sessions in person, and I stayed in Glasgow and delivered mine remotely. So there was no interaction. I've never discussed the public inquiry with Jimmy Walker.
When we talked about the Horn Taps meeting in 2014,
Yes.
which he was present at, and you described, and now the precise moment can't remember when, but Sandra Devine giving it to you in 2018,
Yes.
the minute. And some of your papers have been published with Dr. Walker since that date.
Yes.
On those Teams calls, have you asked him what was going on at the Horn Taps meeting, Jimmy, or anything like that?
Oh, no.
You didn't discuss the Horn Taps meeting
No.
with him? Would that not have been a useful way of finding things out about what happened at the meeting?
I think I already knew from the minutes and what took place afterwards in terms of the risk assessments done locally.
Well, I think that's probably where I sort of run out of speed. I wonder if we can take our 10-minute break at this point to see whether anyone has any questions for me to ask.
We'll do that. I need to discover whether, and Ms. McIntosh needs to discover whether there's any questions that other legal representatives wish to be put. As Ms. McIntosh has indicated, that might take us 10 minutes. So if I can invite you to return to the witness room.
Please stand.
Mr. McIntosh?
I have 5 questions, 2 standalone and 1 little a mini topic.
We have some more questions,
So
Doctor.
the first one relates to Mycobacterium chelonae. And so just to recap where we are, it's June 2019 and the second case has had a positive test. That child has had the infection confirmed. Were there any investigations or swabbing or testing of the ward before then, perhaps in April 2019, looking for Mycobacterium chelonae, and was any found?
So not Ward 6A, but Ward 2A, and yes.
So would that have been part of the... Why would you be swabbing 2A in April 2019?
So this is in relation to Professor Cudahy and discussions that I'd had with him. And at the time of the incident in 2018, we didn't undertake water testing at the time of that case. And at the time, I think we were so focused on the outbreak and trying to bring things under control that perhaps we hadn't put the patient at the centre of what we were doing and the family at the centre of what we were doing. And we didn't do water testing to give them an answer. And they wanted an answer. And just through my conversations with him, I felt it was important to try and give them an answer. And I went back and instructed estate staff to sample Ward 2A.
At that point, Ward 2A was empty?
Cheloney. It was empty, but we found M. Cheloney.
And where in the ward did you find it?
Multiple outlets from taps and showers.
And that would be inside the filters, as it were?
There were no filters at that time because the ward had been vacated.
Thank you. Now, the next topic returns to your statement. Page 292, please. And I think if we look at paragraph 292, paragraph 932, this is a discussion of the HPS October 2019 report, and you absorbed that the sort of information that was being used by HPS interpreting the data was wrong. They're using the wrong methodology tool to demonstrate what they're trying to demonstrate. If it had been interpreted in a different way, it might have been more accurate still. Now, and in my view, this has led to a false conclusion at what's acceptable limit of environmental infections. Now, if I understand it correctly, your main criticism is the use of the SPC chart.
Yes, that's correct. Nothing else.
But would it not be fair to say that SPC chart in context, and particularly in this case, in the context of epicurves and discussion of diversity of organisms, one of which we just looked at, actually can be a useful tool when taken together and viewed in context with care?
I think I would still go back to what I've explained before about their use for organisms that are not endemic, and the difficulty with, in that case, detecting an outbreak accurately. And I would be concerned if we had an SPC chart for gram-negative bacteria, because that doesn't tell me anything about the nature of the bacteria. I can see why HPS would have used SPC charts at the time, because they were a methodology that we were all familiar with for these other organisms. And actually, we don't actually know what the correct chart or tool is for these environmental organisms. And that is something that I've been involved with in my work in RHI, discussing with the data and EPI team as to what sort of chart, if any, is appropriate for the situation where you have environmental organisms. That needs further work, and it needs input from statisticians and epidemiologists. So I understand why they use them, but I still don't feel that they were the most appropriate tool at the time.
And are you able to tell us what would have been the most appropriate tool?
We're still working on that, but we are creating our environmental dashboard, which we're currently trialling with 2 health boards, which is based on triggers, which we've mentioned as part of this inquiry before, and similar to the triggers that I had set up back in 2016. So we are currently running this and seeking feedback from the boards involved as to whether the triggers might be a more sensitive method than using SPC charts.
So would it be fair to say that if SPC charts and their use by HPS at this point had their flaw, in their defence, there wasn't really an alternative available?
Yes, I accept that.
Now, we can then turn to the topic which I'm afraid we didn't discuss, but it seemed we can deal with it, I think, relatively promptly, which is the question of prophylaxis and their use by children, for children at the time once the water incident had sort of become established in people's minds within the hospital as an issue. And what view would you take of the reality that in some cases we had children on additional antibiotics for 6 or 7 months? Is that something that is acceptable?
No, and I think that's a symptom of the built environment at the time and the risk to patients. I mean, prophylaxis for some of these patients will be part of their normal regime, depending on the level of immunosuppression and chemotherapy that they're receiving. So many of them do require to be on antifungals, but we had to extend that. And then we had to use more antibacterial prophylaxis, the antibiotic Ciproxin at the time as well. But it's not acceptable. It's a marker of the risk in the environment.
And what weight or significance should we accord to the impact on their own flora of a long period of time on these treatments?
So with any antibiotic, there will be an impact on the patient's own flora. There is the potential for side effects, as with most drugs. There is the potential for alteration to the gut flora. There is the potential for resistance, so it's always about balance. But the approach we took to it is that patients were reviewed by clinicians on a case-by-case basis to make sure that they should receive the prophylaxis. So not all patients did. It was the higher risk patient groups that did.
And finally, there's some suggestion, I think we've had evidence, that some families were unaware of why their children were receiving certain prophylaxis. How would that have come about?
Usually the clinician looking after the patient would explain why they were on a particular drug. I can't really answer that. I always felt that the clinicians were really open and transparent with the families when we were talking about the incident, but that would have to be a question for them.
Thank you. I think I've got no more questions at all.
Thank you, Ms. McIntosh. Dr. Inkster, that is the end of your evidence, and that means you're free to go. But before you do, can I thank you for your attendance today, your attendance yesterday, and the clearly considerable work that must have gone into preparing your witness statement, which, as Ms. McIntosh has explained, we have read, we may read again, and in fact, we will read again, and is part of the evidence that you've provided to the inquiry. But as I say, you're free to go, and thank you very much.
Thank you.
Now, Mr. McIntosh, I think it's Mr. Connell tomorrow.
Mr. Connell tomorrow for Sandra Devine, the Associate Nurse Director.
Right. And again, we're scheduled to begin it, all being well, at 10 o'clock.
Indeed.
Yeah.
Yes, sir.